You're listening to Medscape's In Discussion series on esophageal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Samuel J. Klempner. Dr. Klempner is an associate professor and director of gastroesophageal medical oncology at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Sam Klempner. I'm a GI medical oncologist at Mass General in Boston, and welcome to this Medscape In Discussion esophageal podcast series. I'm joined by my colleague, Dr. Nataliya Uboha. Today, we're going to be discussing locally advanced esophageal adenocarcinoma, and particularly a couple nuanced scenarios that come up a lot in clinical practice. So before we get into it, let me introduce my guest, Dr. Uboha. Dr. Uboha is an associate professor in the Department of Internal Medicine and Division of Hematology and Oncology and Palliative Care at the University of Wisconsin-Carbone Cancer Center in Madison, Wisconsin. So welcome to In Discussion. We're going to go by first name since we know each other well. So I'm going to jump right into this case, Nataliya. So let's say we've got a 75-year-old patient, otherwise quite healthy, comes in with clinical node-positive esophageal adenocarcinoma, true esophageal cancer. You give the person neoadjuvant therapy, and they have a great response, and they say, I really don't want to have this operation after hearing about an esophagectomy. How do you sort of think about this discussion in your own multidisciplinary clinics?
Hi, Sam, and thanks for having me on this podcast. This is the scenario that does happen quite often, especially in patients who are in their 70s or older. Everybody is worried about esophagectomy, and appropriately so. It's a big operation. And it usually does take some time to talk about pros and cons of approach without surgery. I usually tell patients that it is very unlikely that we will cure patients with node-positive esophageal adenocarcinoma with chemoradiation alone. We know from prior trials, including cross-trial, that pathological complete response with that type of approach is about 23%. And that is still not reflective of all of the patients that we actually cure, because even those that have path-CR, pathological complete response, can recur in the future. So we talk about surgery, and I very much encourage for patients to consider it, meet with our surgeons. And I don't want to say that I push for esophagectomy, but I would like to make sure that patients know that they're not cured with chemoradiation, most likely.
Yeah, and I completely agree. Let's say this patient has a shared decision-making process, goes through, sees all the consultants, and ultimately decides to decline an operation. How do you monitor this patient population?
Well, typically we follow these patients with CT scans. If somebody forgoes surgery, I like to get a PET scan a couple months after completion of chemoradiation. And this time we have more wiggle room because patients don't go for esophagectomy, just to have a better idea of the type of response they had. And subsequently, I follow patients with CT scans, usually every 6 months. For the first 2 years, I only refer patients for endoscopy if they have symptoms. In my practice, I started to incorporate ctDNA into monitoring these patients, not because we know necessarily what to do about the results, but to add to the number of tools we have to closely observe these patients.
Let's say this patient, for example, was HER2 negative, mismatch repair intact, but PD-L1 very high, let's say CPS 15. I think there's sort of an inertia, especially from people who care for multiple different tumor types, where maybe they've seen consolidation PD-1 for lung cancer, and they say, well, is this an appropriate scenario for esophageal cancer? Is this something we have any data for, or how do you think through that conversation?
Well, it is tempting to use adjuvant immunotherapy in this setting, but it's not driven by data. We do have data for the use of immunotherapy in similar setting in a locally advanced and resectable lung cancer, but this has never been established as standard of care in esophageal cancer. In esophageal cancer, we use 1 year of adjuvant nivolumab after chemoradiation and resection in patients who has had residual disease at the time of resection, a residual pathologic disease at the time of resection. Here, we're taking a big piece of the treatment out of the picture. We're taking esophagectomy out of the picture, so we have no idea whether immunotherapy helps or not. To be frank, I have used it once or twice in my practice, but again, this is not supported by any data. And really, PD-L1 score doesn't help us in this situation. And it also does not help us in patients who have resectable or who actually undergo resection, because we know that PD-L1 expression can change with radiation.
Yeah, I agree. It's certainly a scenario we get a lot of questions about, and I think our approach has generally been, outside of one-off cases, not to offer consolidation or maintenance checkpoint inhibitor in the absence of an operation. I know that you're going to be the discussant at ASCO in a month or so, talking about some data sets. Can you just remind us, very high level, what the trial was and what the question is?
So the trial was designed to answer the question whether using immunotherapy before and after resection will help patients. We now know, as I've alluded to, that adjuvant nivolumab does help patients who undergo chemotherapy and radiation and resection. And so the trial was designed to ask a question: what if we actually use immunotherapy earlier? What if we add immunotherapy to chemoradiation? Will it help patients? So there was a randomization before surgery. And then there was another question the trial was asking a question whether intensifying adjuvant immunotherapy will also help patients. So there was also randomization to either nivolumab or ipilimumab and nivolumab after resection. And so we'll hear some of the preliminary results from the study at ASCO. The primary endpoint of the study was pathologic complete response at the time of the resection. That was one of the earlier endpoints. So one of the endpoints was to look at PathCR, pathologic complete response, after the addition of nivolumab to preoperative therapy, and we will learn about the results of that portion of the trial at ASCO.
It's sort of a question relevant to this case of someone who has a great clinical response and opts to decline surgery. Do you think that we will get to a place in the relatively near future where we will have tools in the neoadjuvant setting where we can actually identify people who might not need surgery? Or you feel like serial endoscopy, bite on bite, ctDNA, maybe we just don't have the sensitivity to get there yet?
I'll give you my thoughts, but I would be curious to hear what you think as well, Sam. I think the issue with esophageal cancer and our current treatments right now is that there's a very tight timing between the end of radiation and esophagectomy. If we continue to use chemotherapy and radiation preoperative setting, then we know that esophagectomy is safest within a certain period of time. And I think the problem is, and within those 8 to 10 weeks after the completion of chemoradiation, it will be hard to know with certainty that the disease has been cleared, especially knowing that chemotherapy and radiation continues to work for months, and also the fact that random biopsies are not a reliable indicator of pathologic complete response. So I think with the current tools right now and with the current approaches right now, we are not close to foregoing esophagectomy in patients who are treated with preoperative chemoradiation. And I think radiation is a big piece of that. What do you think?
Yeah, I think we all hear the patient perspective and understand there's a very strong desire in the community to find a way to avoid an operation because it is a big surgery. But curing cancer is, of course, the priority in this paradigm. And I agree. I don't think we yet have the tools to clearly identify who we can say you're likely to be cured with preoperative chemotherapy or preoperative chemoradiation and therefore can avoid an operation. I do hope that, work that you're doing and work that other people are doing will help us get there. And it's definitely a valid question to ask. I agree. I mean, in a fit patient, we're recommending surgery as the standard of care for cure in this setting.
I also think for people who undergo preoperative chemotherapy, you have a little more wiggle room and more time to figure out what's happened to their disease. For those who have radiation, because of the scarring that sets in, and salvage esophagectomy is a more complicated procedure, I think you'll have less time to really decide, is surgery a go or no go?
Yeah, that is a good point. All right, let's carry this case forward, as unfortunately happens for many patients. So let's say a patient opted to forego surgery, 2.5, 3 years go by, and ultimately the patient recurs. We said they're PD-L1 positive, you don't have an available trial, and you start them on standard of care, Fulfoxan checkpoint inhibitor. Things are going well, patient has a response on their first imaging. This is another question that comes up a lot. So are you someone who likes to think about dropping oxaliplatin at a pre-specified time, like length of exposure, or do you base it on symptoms? How do you approach this conversion and long-term management in the frontline setting?
I definitely base it on symptoms, and it's a personalized approach for each patient. Some patients come in and they already have some neuropathy, either from diabetes or for other reasons. So I tend to drop oxaliplatin earlier. In patients who have no symptoms and have no neuropathy, to start, we're able to give 4 to 5 months of oxaliplatin. So in those patients who are tolerating okay and are responding, I treat till maximum response and then stop. Ultimately, it happens somewhere between month 4 and 6.
Yeah, I think my experience is typically month 4 to 6. I know even some trials mandate after 4 to 6 months, depending on the design and the chemo backbone. But I think that it's an important lesson. These are people who are in it for the long run, and we don't want to beat them up too much with oxaliplatin such that they have platelet counts that can't get on to second-line therapy or are no longer eligible for trials, etc. I think that's something that you, as someone who sees a lot of this disease, obviously expert at. So let's say things are going well. Patient is having some fatigue and quality of life may be starting to be impacted a little bit, but otherwise is tolerating 5-FU and Nivo. Do you try to keep the 5-FU Nivo or do you feel comfortable with transitioning to, say, like monthly Nivo as a maintenance strategy? Or do you, again, individualize?
I definitely keep 5-FU Nivo in my patients, and I definitely don't take treatment breaks. This is the disease that once it starts to progress, it's hard to get control of. The question of whether maintenance immunotherapy alone is an appropriate approach has been asked in a randomized trial. They used avelumab in that setting. It was a negative study, one of the Javelin studies. So I think chemotherapy does play a role. So I continue 5-FU nivolumab.
Yeah, I agree. Generally try to keep the chemo on board. Same question, let's say HER2 positive patient and also PD-L1 positive. Same approach?
But I keep trastuzumab. So it's usually 5-FU trastuzumab and pembro.
Totally agree. And so I know, again, at ASCO, it will be nice to see some data asking this question about continuation of frontline therapy until progression versus an arbitrary, well, let's call it early switch maintenance to a second-line regimen. Tell us a little bit about this Armani study and, again, just the question.
So Armani was a phase 3 study that asked a question of switch maintenance. I like the way you framed it. It's an early transition to second-line therapy because the switch maintenance arm in that study was ramucirumab and paclitaxel, which all of us right now use in second line. And so the trial asked a question, is it better to actually start this therapy earlier before patients develop resistance to frontline chemotherapy?
Yeah, it's a fair question. I know in the lung cancer literature, again, we take some pages from our colleagues, and they have some positive PFS trials, I believe, but my understanding is it's not common practice to switch to early second-line therapy in patients who are otherwise doing okay.
Exactly, and it comes with different types of toxicities. Without the results of the study, I would not use this approach. It makes me nervous about using up all of my tools up front. However, if the study is positive, it would be a potentially practice change in study.
Yeah, we'll have to bring you back after ASCO to follow up this after these data sets get released. So let's say this patient has continued on 5-FU Nivo for a year, did quite well, and then pops up an isolated lesion. I want to talk a little bit about this scenario, but also oligometastatic disease in general. So let's stick to the case for a second. This is an isolated area of progression. In your multi-D tumor board discussions, tell us a little bit about what your conversations usually happen in that scenario.
Well, if somebody has been on therapy for a year, has had stable disease, and now they have a new lesion or oligoprogression, we always ask the question, why? So I actually like to get follow-up biopsies after an extended period of time for updated biomarker results. I think this is more relevant for patients that have HER2 positive disease, but in this scenario as well. And then we always ask the question, will this patient benefit from local regional therapies like radiation? Typically don't think about resection in this cancer because continuation systemic therapy is very important. So, when somebody has oligoprogression, which we don't see often, but we do see in this disease, we ask the question whether any local regional therapies could help, such as radiation, for example. Tend to stay away from surgery in this disease because any resection will require a break in systemic therapy. And we already talked about the fact that continuation systemic therapy is important for this disease.
You mentioned ctDNA earlier. One thing we've thought of doing a couple times, and honestly I have done a couple times, is in these oligo-met scenarios, the question is like, is it truly the tip of the iceberg and they're about to have 3 more lesions, or is it true that's the biology? have you thought about, ctDNA like pre-ablative therapy and post, and using, let's say, conversion from positive to negative as a reassuring that you got it all, or you got everything that you can detect or see?
I have used this approach in isolated scenario across different tumor types, including biliary tract and colon cancer. I think until we get a larger body of information, it is hard to interpret what these results mean, because also ctDNA doesn't always clear when we just ablate or radiate the tumors, because this is not a true physical removal of the tumor of people's bodies. So it doesn't go to zero immediately. So the timing of it becoming negative is an unknown. But as you know, you and all of us in academic centers are collecting this literature, and hopefully we'll be able to learn more from each other as we put all of this together. But only for academic interest, I guess, at this time.
Yeah. And then let's back this case up a little bit. And let's say a patient recurred and had an isolated liver lesion as their recurrence and no other disease. Tell us a little bit about the frontline management of oligometastatic disease, and particularly the data that we have and your own study that's trying to answer this important question.
So we have known for years that there are some patients with oligometastatic gastroesophageal cancers that benefit from more aggressive treatments. What we don't know is exactly who those patients are and how best to approach them. And there has been an ongoing phase 3 study in Europe, Renaissance study, the results of which will be presented at ASCO, asking a question of surgical resection of oligometastatic sites with gastric cancer and seeing whether that helps in patients who are also getting systemic FLOT chemotherapy. I am chairing a phase 3 EA2183 study that asked the question of whether local regional radiation to all sites of disease helps patients who have oligometastatic gastroesophageal adenocarcinoma. We all have patients in our practice where we've used these approaches, and we feel like we've helped them. We've had exceptional responders, but until we actually do a randomized study, we do not know whether this is the appropriate treatment. And more recently, we've had actually randomized studies in breast and lung cancer, and the largest studies have had negative results, unfortunately. So it is very important to ask this question, try to answer this question in a perspective manner.
Yeah, completely agree. I mean, this is a conversation that comes up a lot in our tumor board, and we have exactly the debate that you just said, and we feel like we know people who we might want to think about this, but if we're honest, we really don't have the data to say one strategy is better than another.
Yeah, and there's so many different variables. Is how many sites of the disease? Does the organ matter? Does it matter the size of the lesion? How long is enough to give systemic therapy? Do people with different biomarkers benefit differently? So all of this is unknown right now. And then, as you mentioned earlier, is incorporating the ctDNA, which hopefully will be a much better biomarker than just imaging scans to really identify patients who have oligometastatic disease.
Yeah, I mean, I think a lot of hope for our patients over the coming years as we hopefully transition this disease into more like the outcomes we get for colorectal, like you mentioned, or even breast or some of these other tumor types where we have more reliable, durable outcomes. So today we talked to Dr. Uboha about locally advanced esophageal cancer, particularly the management decisions and thoughts around people who opt not to undergo esophagectomy and questions and data sets that may help inform this practice in the future. We talked about practical management of frontline maintenance, thoughts around when to drop oxaliplatin, importance of continuation of some form of chemotherapy, and then the management of oligometastatic disease, which are all clinical scenarios we all see in patients. Thanks to Dr. Uboha. Thanks to everybody for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on esophageal cancer. And on behalf of the Medscape in Discussion podcast, thank you very much for joining.
Thanks for listening to Medscape's In Discussion Esophageal Cancer podcast series with our host, Dr. Samuel J. Klempner. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on esophageal cancer.